Hey everyone, and welcome to this explainer. We are jumping right into a really fascinating, high-stakes topic today. We're going to take a detailed, step-by-step clinical journey through one of the most critical challenges in pediatric care: esophageal atresia and tracheoesophageal fistula. We'll trace the patient's path straight from the very beginning of life, right through to post-operative recovery, and unpack the exact clinical protocols that make survival possible. So imagine for a second that the human body is a complex, perfectly engineered plumbing system. But what happens when a baby's digestive and respiratory pipes cross wires before they're even born? Well, it's not just an anatomical quirk, right? It's an immediate, life-threatening crisis the very second that baby takes its first breath or tries to take its first feed. Okay, let's dive right into our roadmap. We'll start with the anatomy of the malformation, then cover spotting the warning signs, move into stabilizing and surgical repair, look closely at fluid balance and recovery, and finally navigate the potential complications. Section 1. Anatomy of a malformation, the pathophysiology. To really grasp this, we've got to rewind to the early stages of embryonic development. During the 4th and 5th weeks of gestation, the foregut normally lengthens and splits into two distinct parallel channels, the esophagus and the trachea. But in congenital esophageal atresia, or EA, and tracheoesophageal fistula, or TEF, you get a separation defect. Normal growth just stops at a crucial stage. The result? A complete failure of the esophagus to develop as a continuous passage, and a failure of the trachea and esophagus to separate like they should. Basically, the pipes are either leading to a dead end, or they're connected to the completely wrong system. And here's the harsh reality. This rarely happens in isolation. About 50% of these cases are part of a broader spectrum of anomalies known as the VADER, or Vactoral Association. This acronym is basically a vital checklist for clinicians. It stands for vertebral defects, anal issues like an imperforate anus, cardiac anomalies, tracheal and esophageal defects, renal and radial dysplasia, and finally, limb anomalies. Because half of these infants will have other severe structural defects, especially cardiac ones, every single patient needs a full comprehensive medical workup to catch these issues right away. And this brilliantly illustrates what we're dealing with anatomically. Notice that variation right in the middle. That's the most commonly encountered form, making up 80 to 90% of all cases. You can see the proximal, or upper, esophageal segment just ends in a blind pouch, a total dead end. Meanwhile, the distal, or lower segment, is abnormally connected directly to the trachea, or primary bronchus, by a short fistula. You can easily imagine how this specific setup is just an absolute recipe for disaster once fluids or secretions get introduced. Section 2. Spotting the warning signs, prenatal and postnatal diagnostics. The clues actually start popping up before the baby is even born. Prenatally, a massive red flag is a history of maternal polyhydramnios. That's an abnormal accumulation of more than 2,000 milliliters of amniotic fluid. Why does that happen? Well, normally a fetus swallows amniotic fluid, absorbs it in the GI tract, and excretes it. But with EA, that blind pouch means the fluid can't reach the stomach, so it just builds up in the womb. Then, postnatally, the very first nursing physical assessment provides a critical diagnostic roadblock. If a nurse tries to pass a small-gauge orogastric feeding tube into the stomach and it hits a dead end or coils right back up, EA is immediately suspected. Now, if that anatomical block wasn't caught by a tube, the clinical signs will give it away really quickly. I want you to remember this rule of 3 for the classic warning signs: frothy saliva, choking and coughing, and cyanosis. A newborn with EA will often have excessive frothy saliva bubbling from the mouth and nose simply because they cannot swallow their own drool. If someone tries to feed them, they might swallow normally for a second, but then suddenly gag, cough, and return fluid right back through their nose and mouth. And that leads to the third sign, cyanosis and apnea. That cyanosis is often a laryngeal spasm caused by the overflow of saliva into the larynx from that upper pouch, literally cutting off their air supply. Section 3. Stabilizing and surgical repair. Immediate therapeutic management. Let's move to the immediate management phase, where every single second counts. The major goal here is establishing a patent airway and preventing respiratory compromise. First, the infant is immediately made NPO, absolutely zero oral intake. Second, IV fluids are started to keep them hydrated. Third, we position the infant supine with their head elevated on an incline of at least 30 degrees. This is absolutely crucial because it minimizes the reflux of acidic gastric secretions up through the fistula and into the lungs. And fourth, a double lumen catheter is placed into that upper blind pouch and hooked up to continuous low suction to clear out accumulated saliva. If we skip this, the infant risks aspirating secretions or stomach acid, which can cause a lethal chemical pneumonitis. Once we've got the infant stabilized, it's time to fix the plumbing with surgery. Today, thoracoscopic repair is often used, which is a real game changer because it avoids a highly invasive full thoracotomy and really minimizes post-op complications. The surgeon divides and ligates or ties off the fistula connection to the trachea and then performs an end-to-end anastomosis, effectively sewing the two halves of the esophagus together. Now, if the infant is premature, unstable, or if the gap between the two segments is just too large, like greater than 3 to 4 centimeters, they might need a staged operation. They'd start with a gastrostomy to feed the baby, tie off the fistula to protect the lungs, and drain the pouch until the baby grows enough to attempt a delayed connection weeks or months down the line. Section 4. Fluid balance and recovery. Crucial post-op clinical pearls. Because the infant is NPO and relying entirely on IV fluids, we really have to understand exactly where that vascular volume is going. Now, what's really interesting here is a crucial clinical pearl. Higher protein and albumin keep water in. Think of albumin circulating in the blood like a molecular sponge. It maintains oncotic pressure. It literally holds onto the water, keeping the fluid inside the vascular space where it belongs, rather than leaking out into the tissues and causing swelling. To safely administer IV therapy to a tiny infant who can't eat or drink, we have to perfectly balance electrolytes across the body's compartments. Potassium is the primary ion located mostly intracellularly, so inside the cells. On the flip side, fluid and sodium are located mostly extracellularly, outside the cells. If a baby is losing fluids, what else are they losing? Significant sodium. And that directly dictates how we formulate their specific IV replacement therapy. And this leads us to a massive, absolutely critical warning for any clinician managing pediatric fluids. Listen to these unpolished clinical notes straight from the source material. A shift too rapid. Water no electrolytes. Correct too rapidly. Water intox possible. If we give fluids without the proper balance of electrolytes, or if we correct a dehydration deficit way too fast, the sudden influx of plain water rushes straight into the cells. They stretch out and swell. This can literally lead to life-threatening water intoxication. Fluid replacement in a tiny post-op infant has to be a slow, meticulously calculated drip, never a rapid flood. So, how do we physically monitor this at the bedside? How do we know if the infant is retaining water? We assess for edema, but in pediatric care, consistency is everything. You don't just eyeball the baby, you measure. You do it at the exact same time every day, like say in the morning after a diaper change and before a feed. The infant needs to be laying flat. And crucially, to bring this into the grounded reality of bedside nursing, you measure at the exact same spot. A standard best practice is to literally make a physical mark over the umbilicus so that every single nurse on every shift is measuring the exact same circumference. Section 5. Navigating potential complications. Long-term monitoring. Even with an absolutely flawless surgical repair, the reconstructed anatomy is fragile. We have to be on high alert for anastomotic leaks, where the surgical connection fails, or strictures, where scarring narrows the esophagus and causes dysphagia or difficulty swallowing. Another big one is tracheomalacia. Remember how that dilated upper pouch was pressing against the trachea during fetal development? Well, that compression causes weakness in the tracheal wall. Later on, this shows up as a distinct barking cough, stridor, or wheezing because the airway is floppy. On top of that, gastroesophageal reflux, or GER, is incredibly common and might even require a subsequent surgery like a fundoplication if it's causing aspiration. So the crucial point is this: vigilant bedside nursing is what ultimately secures the infant's recovery. Post-op, vomiting is a huge red flag. It's a massive aspiration risk for a healing esophagus. We have to meticulously track the content, amount, and color of any vomit. Is it bilious? Is it red with blood? Furthermore, vomiting leads to dehydration and the loss of stomach acids, which can rapidly throw the infant into a state of metabolic alkalosis due to severe electrolyte loss. Every single ounce of fluid in and out has to be accounted for. Now, I know that all sounds incredibly intense, but here's the amazing part. Despite all these risks and the sheer complexity of the repair, the prognosis is a phenomenal success story. In otherwise healthy children without lethal cardiac anomalies, the survival rate for EA and TEF is nearly 100%. With rigorous medical therapy, careful nutritional support, which might mean a feeding tube for a while, and extensive education to help parents navigate feeding at home, these infants don't just survive, they go on to truly thrive. It truly is a marvel of pediatric care. And I want to leave you with this final thought. Considering the extreme precision required to literally rebuild a newborn's anatomy within hours of birth, how does mastering these foundational fluid, electrolyte, and post-out nursing protocols fundamentally change that child's entire lifelong trajectory? It is literally the difference between a tragic outcome and a lifetime of possibility. Thanks so much for joining me on this explainer today. Keep asking questions and keep learning.